Fine. So right now. Good morning, everyone. Welcome to TeleShadowing. Today's topic is going to be on healthcare in the United States. Dr. Chima will be here to answer any questions as our student panelists, one MD student from the University of Maryland School of Medicine and one BSDO student from the Seton Hill University and Lake Erie College of Osteopathic Medicine, take the lead on this topic. Thank you.
All right, good morning, everyone. My name is Minahil, and this is Hamza. We'll be kind of tag teaming today's topic today on the American healthcare system. So this is a brief outline of what we're going to be going over. We're going to be providing you a historical context on why the American healthcare system is the way it is today, the healthcare systems that exist internationally in the UK, Canada, and France. We'll talk about the current state of health insurance, including the Affordable Care Act, Medicare, Medicaid, and then finally, we'll close with healthcare reform and things to consider for the future. So I'll start off with history, a brief history lesson. So basically, in the 1800s to early 1900s, physicians were not wealthy. This actually changed at the turn of the century, where surgeries became more common, hospitals changed into scientific institutions, and the American Medical Association became this force in lobbying and a strength and basically a strength. So health insurance was born as the costs of healthcare increased with more scientific advancements. But this eventually turned into a political issue because the American budget, the United States budget, it kept increasing for healthcare. It turned into a political issue where in 1915, the presidential campaign with Theodore Roosevelt, he was with the Bull Moose Party, and also the 1920 Commission on the Costs of Medical Care also discussed it. So, in the 1930s, the Great Depression happened. This was the first time in history that healthcare costs became super unbearable, and the nationalized health insurance was proposed. This was actually part of the FDR's New Deal. If you remember that Franklin D. Roosevelt, he actually introduced a New Deal where he signed many federal programs, including Social Security, and the Housing Act, among others, to alleviate this crisis. So actually, the national health insurance was debated during the time Social Security was also introduced. And many historians feel that like FDR could have nationalized anything he wanted at that time. So why is there still no NHI in the United States? Well, I would say the reason is multifold. There's not necessarily one specific reason, but it's multifaceted. Um, Really, it was the American Medical Association who was really very fiercely opposed to the NHI. They feared that physicians would be forced into group practices, which is ironic because, spoiler alert, many physicians are in group practices today. They feared that physicians would be paid via a salary or by capitation. So it is very interesting today. Physicians, a lot of them are salaried. Um, and also there were Southern Democrats and Republicans, but in the South, really, so Southern politicians were very opposed to it because of risks of the expansion of government. Basically, during that time, the South really did not want to have more and more federal control over government. There's always been this sort of like pulling each other, like at the state level, the state power or federal power, right? And Hamza, feel free to interrupt me in case I say anything.
Yeah, sure. If I remember correctly, the reason why the South has historically been pretty opposed to federal power is just a lot of hesitancy that comes from the post-Civil War era. There's a lot of issues during Reconstruction, a lot of issues just in general. The Civil War caused a lot of people, even to this day, to still be opposed to the federal government or overreach of the federal government, I should say.
Exactly. Or yeah, so many of the Southern politicians were suspicious that these bills were increasing the size of the federal government that would eventually trample on state rights. So that brings us to, thank you, Hamza, World War II, where while Social Security was passed, the FDR felt that this was something he could address after the World War, but unfortunately he passed away, before he could do that. So that was an opportunity, but unfortunately that didn't happen. But I would say the core reason why we have the insurance that we have today, like employer subsidized insurance, so we get our insurance from our employers, is because of the 1943 War Labor Board ruling. Basically, when inflation became this huge problem, it made rule like basically politicians were passing on rules that limited wages that employers could offer. So to lure in workers, employers could offer more benefits in the place of wage benefits, including healthcare. So that was a good way to maintain the economy at that time. And so when health benefits were given to workers, among other benefits that couldn't be taxed, the employer subsidized insurance was born. All right, but in the post-war years, under President Truman, there was the Red Scare, which is this fear of communism. He did try to continue the agenda of healthcare reform started by Roosevelt, and he did win some campaigns with a fair deal one-payer system, but it never really took off, primarily because the AMA, American Medical Association, and Southern politicians were again against it. They called it a communist plot, but also the ESI was working too well. A lot of like there was actually the United Auto Workers. They were able to negotiate for health insurance and pensions. It was working pretty well at that time. Other industries followed suit, so they were able to better negotiate prices. And who doesn't want to save on taxes? So these corporations were sort of um, you know really
One
enjoying the ESI.
one thing I do want to add about that, this whole situation here, even though we're not in the McCarthyism era anymore, this is one of the main reasons why the US to this day doesn't have a fully nationalized healthcare system, because many people are very, very hesitant about the government taking over any industry due to the Red Scare. That's why, and this is something that is actually pretty unique to the United States. This staunch opposition to socialization. You actually don't find this in a lot of Western European countries or even in Canada, which is a northern neighbor. This is a very specifically American phenomenon that I'll be covering more.
Exactly. No, thank you for adding that. That's very important. But yeah, then the Great Society started to be introduced by President Lyndon B. Johnson. And actually, Hamza, you can talk about this about the per capita spending at the time.
Yeah, so I included this little bit of information here just to show that this is around the time where our current healthcare spending crisis really began. In 1950, according to the SSA, the per capita spending for healthcare per person, that is, in the United States was about $84. That would double just 14 years later by $191 in 1964. And that was around the time where, again, the Great Society was done by President Johnson. And from that point, the healthcare prices have skyrocketed.
Exactly. And it just kept on increasing. It led us to, Medicare and Medicaid. They, were introduced in 1965 as part of the Social Security Act that was reintroduced then, where Medicare was a federal program for geared towards older individuals, and Medicaid was this federal and state program for the low-income individuals. We do have it today, but many, many changes have been made to it because there were many problems that arose with this. Now let's go to the 1970s. We did the 1960s where healthcare prices are increasing. Now in the Nixon era, there were no cost measures on Medicare and Medicaid. So the budget kept increasing, which is actually one of the highest budgets in the world. The United States kept spending more and more on healthcare than any other country did. And today it's still true where the United States spends more on healthcare than any other country. Even though now, does that mean that we have better health outcomes? That's something to think about, and we'll explore as well. And also in President Carter also tried, but unfortunately, because of politics and scandals, it led to a lot of lost opportunities. And so Watergate had this it was like ultimately that lasting detrimental effect on the possibility of healthcare reform under Nixon's administration. President Carter also tried, but unfortunately, lobbying was very strong, and that also couldn't happen. So yeah, a lot of politics and scandals really led to that. Then the 1980s, then the Reagan era, that's when the cost-cutting measures were implemented. And that's actually when diagnosis-based billing was introduced. That's something that we have today now. I don't know if you've heard of these acronyms, HMOs, PPOs. I'm still learning what that is, but I know that that's when they were first introduced, the health maintenance organizations. Um, Then in the Clinton era, something that we might remember or have heard a little bit more about, President Clinton and Hillary Clinton tried introducing a plan, but unfortunately it was too complex and hard to understand. So, Clinton was not elected with a mandate either for it. So the Health Insurance Association of America and even the National Federation of Independent Business strongly opposed the bill. Because, like I said, ESI, the employer subsidized insurance, is working very well for companies and tax saving measures. So that brings us to really the early 2000s as well, where, to this point, the only major changes that happened in between the 60s with the Medicare Medicaid was in 2006, Medicare Part D was added. And in the 2000s, there was actually the SCHIP, which stands for the State Children's Health Insurance Program, which, there haven't really been major changes made. So a quick recap of what we've gone over so far. Doctors started being paid for their services. ESI becomes huge because of World War II and inflation. Then Medicare and Medicaid try filling in the gaps for ESI. But as you can see, as more and more problems arose, we just kept kind of building on top of a house that had a very weak foundation. Sort of like if anyone has watched Harry Potter or read the books, it's sort of like the burrow, where you're kind of building a house on top of another, sort of in Harry Potter's best friend. What was his name? Hamza, do you remember? You're muted.
My bad. You mean Ron?
Yes, Ron's house. So basically, this is sort of Ron's house. It's a good analogy that I might revisit again for all these different programs that kept being added on top of each other, and then just adding more band-aid solutions when something bad happens. For example, 2008, the recession. So unfortunately, there were a lot of lost opportunities for healthcare, starting with FDR, his passing away. That happened. Then the Watergate scandal, even though President Nixon did intend to make some healthcare reform and changes, the American Medical Association became a very strong lobbying force, and a lot of businesses wanted to save money, right? So America is unique because we are a very highly capitalistic society, because we wanted to not be like a communist society. So we became more and more hyper capitalist. All right, now I'll hand it off to Hamza to discuss a little bit about like the international healthcare systems worldwide so we can compare.
Yeah. So I focused on 4 specific countries to look at because these countries are actually very often touted as examples for the United States to follow. One is, again, our northern neighbor, Canada. I mentioned the NHS for Scottish and English. A lot of people don't know these are actually separate systems, and I'll explain that a little bit, and France. So off to Canada. So in Canada, it's also called Medicare. In the US, we have Medicare. Canada also has Medicare. It's divided by different provinces. So like we have states, they have provinces. Each province decides how taxes are run, what services are covered. So for example, some provinces do cover prescription drugs or dental care. Other provinces don't. It just depends on which province decides to do it, how. And again, it's paid by taxes. It's not paid necessarily out of pocket. Private insurance, though, does exist alongside their Medicare system. So a lot of Canadians do opt for that. Usually, this private insurance is something that pays for things that may not be covered in a certain province, as again, prescription drugs and dental may not be covered. One of the downsides to the Canadian system is that something it's really well known for is long waiting time for specialists. This is a result of budget constraints that sometimes may occur or a high demand due to free healthcare. So what may happen, for example, is everybody sees that this healthcare is free, so they might as well go take it, right? They don't have the urge to maybe say, do I really need to go or not? They just go ahead. So this creates a high demand, and as a result, a lot of physicians are taken. And priority is usually given to the urgent cases. So if you have a less urgent case, again, you have to wait a little longer to meet that specialist. In England, the English NHS is often touted as a very, very good program, which in England is actually not popular at all. So it was made after the Second World War, targeting generally single conditions. So for example, if you have a lung issue, it's targeting that. But as time went on, our life expectancies increased, and people now have regular visits. So for example, if you have arthritis, you're going to the hospital or going to the doctor a lot more often. And as a result, the system that was made just to like save lives is now having to transition over to maintaining your life. From the very beginning, bureaucracy actually caused a lot of issues with the NHS, again, since the 1950s. And then in the late 90s and early 2000s, Tony Blair, who was the former leader of the United Kingdom, his government used quotas to simulate the NHS working like a privately owned entity. So what that means is that when you have a business in the free market, you're going to be trying your best to compete with everyone else around you. So you're going to try to lower your costs and make yourself the most efficient and best quality as possible. Now, it did technically make the NHS more efficient when it comes to quantity, but what that led to is that the NHS is now checking off boxes because now you have these quotas, you're meeting those quotas. And as a result, the actual quality of the healthcare decreased. And that's why the English NHS is not liked at all. Well, it's respected, but it's not as good as people think it is. But
Hamza, I've also heard about like physicians, you have to have symptoms to go, right? And visit someone in NHS.
I'm not sure if that's true. That's again another downside. So
Okay.
yeah. Now the Scottish NHS is very different. The Scottish NHS is actually a pretty good system. So recently, like within the last few decades, there's been a process called devolution in Scotland. If people don't know, the United Kingdom is made up of multiple countries. It's a country made up of countries. So there's Northern Ireland, Wales, England is the most famous, and Scotland in the north. Um, and historically, the Scottish and English, they've always had fights. Scotland wants independence. I think in 2014, I remember there was a referendum for independence. Regardless, devolution is a process that Scotland has gotten more autonomy from the central British government in London, in England. So in 1999, Scotland actually got its own autonomy over its NHS. So the way the Scottish NHS works is, for one, it serves a smaller population. Everybody knows that England is very populous. England literally controlled most of the world for a period of time. London is one of the economic centers of the world. So Scotland is a lot more rural. Its big city, Edinburgh, is, I think, smaller than the five big cities of England. I may be wrong about that. Um, so in general, you have much less people to serve. On top of that, the way they deal with it is that they split the NHS into 14 smaller health boards. On the map on the right side, you can see all the little smaller health boards that they split it into. That makes it easier because if you're dealing with something localized, it's easier to know what you need in your locale. They maintain a smaller bureaucracy. Again, bureaucracy plagued the English NHS really bad, and they integrated social and healthcare. So social care includes preventative care, just making people's lives better. And as a result, you're not dealing with people who weren't having preventative care. As a result, you're not dealing with as many patients per capita. So the Scottish NHS is generally seen as more of a success than England. And that's what I have to say. Now, do you want anything about the Scottish NHS?
Yes, I wanted to ask, now that you're talking about like population per capita, Canada has a lower population as well. So could that also be why the Canadian Medicare is working, right? It's still operational and not as, I guess, compared to the England NHS.
It's possible, but the next country I do have is France. Now, it's a
Mm.
different type of system. I'll answer your question while going through this. So France, I think either France or Germany, excluding Russia, is the most populous country in Europe. I don't know. I don't remember which between the two besides Russia is the most populous, but one of those two are. France is really well known for its high quality of care. They use this thing called the statutory health insurance, or SHI, for all residents of France, and that's paid for by deductions from the salary of workers. Now, the interesting thing is something I learned while doing research. When you're in France and you go to the hospital or you go to the clinic, you pay upfront whatever the cost is, and then you're reimbursed about 80% of the cost afterwards. Sometimes it could be 100% that you're reimbursed. Sometimes it could be 30%. It depends on how much, depends on what's going on, what the procedure is, how much you're reimbursed, but you generally are reimbursed a good amount afterwards. So what this actually does is that it actually makes patients less likely to take advantage of the system if they know the cost. So I remember how I mentioned in Canada, people just went to the clinic for anything because healthcare was free. In France, people are less likely to do that because now they know the cost. So I don't necessarily think it's population alone. I think the bigger thing for the English system was just the bureaucracy and the fact that they made these false quotas to make it run like a business when it's not a business. And the issue with Canada was that the system, I don't want to say abused because it's not necessarily abused, but people really use the system more than they genuinely need to. And as a result, it becomes bogged down with all these patients to deal with. So anything not covered by the SHI, again, remember how in Canada there's certain things like dental that aren't covered. That has optional private coverage. You can get private insurance if you want. There's a strong focus on preventative care and primary care. And again, we'll touch more on preventative care. Notice how both France and Scotland uh, have preventative care as a major goal. Um, there's less entangling bureaucracy than the English NHS. But here's the big thing, though. It's paid for by about 12 to 15% of France's national budget. France's system is on one of the opposite extremes when it comes to socialization in the world. So if the United States wants to adopt a France-like system, and again, I'm going to touch on this a little more later, they really have to look at the fact that this is a very expensive, tax-heavy system that we want to use. But these are the systems that I'll be comparing the most when we talk about potential future actions. Is there anything else you want to add, Minaho, before we continue?
Yeah, I had a quick question. Maybe um, about like so saying patients are paying up front, but what
Yeah.
about patients who are not able to afford it, right? Or just like as doctors, we know that like in the future we cannot decline and treatment, right? We know the hospitals in the U.S. at least in emergency departments we never say no to anyone who needs medical care or medical attention during emergencies.
I mean, I'm not sure what they would do for a patient that can't afford it.
Mm.
I'll look into that while you're actually doing your next part to
All
like
right,
answer. But
awesome.
I don't think they would straight up turn somebody away. I think this is more so just to make sure, as a preventative measure, to make sure people don't take advantage of the system.
Right. What I like about this is like when you're the thing is like with American healthcare is the cost after usually like after you go through it you're not really told but Congress tried I think they passed the No Surprises Act which I think was watered down from its original intention, but the No Surprises Act does say like you cannot have surprise medical bills after your medical care, just like you can just have one billing summary and you can't just like keep billing on top of that, which a lot
Yeah.
of physicians have been doing since the 1900s, ever since billing was introduced.
Hmm. So yeah, here's some general differences that between America, just general, not even in those specific countries I mentioned, just around the world, how different socialized systems do it. So other countries are more likely to have restrictions on unhealthy foods. This is something obviously we don't see in America. European food and drinks generally have a far less sugar in them. So like even cereal, soda, whatever it is, if you eat them in Europe, apparently they're a lot less sweeter than they are in the United States. Um, I mean, something I learned very recently, we had some businessmen from Turkey visit recently. And I was speaking to them about carpets because that's what they sell. And they mentioned that certain rugs are banned in Germany that they saw like here in the US. They say, yeah, that kind of rug is banned in Germany and in most of Europe because there's artificial coloring, and artificial coloring is obviously bad for your skin and stuff. And the laws there prohibit things that are generally bad for you. I mean, even serving size for fast food, as I mentioned, is less in Europe. I had a friend from Italy. He came to my school in my college. He was my neighbor in my dorm. And I remember we went to Walmart with him for a day that we wanted to cook. Every time he picked up like a box of whatever it was, like, whether it was bread or whatever, he'd see high fructose corn syrup and immediately put it down. And he mentioned to me how everything there had high fructose corn syrup. That's not something that exists in Europe. Or maybe it exists, but at a much lesser level. Um, the reason being that the promotion of a healthy lifestyle is very common in these systems. Exercise is promoted, healthy food is promoted, sports is promoted to that friend when he was very young. I mean, the guy himself, he is very built. The reason being that unhealthy people are seen as a burden on the system. Why? Because if everybody's paying taxes towards this healthcare system, everybody wants to benefit from it. But if somebody out there is not taking care of their health at all, and they're just using the system to babysit them essentially, the society ends up looking at that person as a burden, right? And that is a burden for the system if people are just abusing it in that sense. That's why, again, Canada has this problem that we just mentioned. So something, again, I'm going to have to say, again, we're going to look at it later, but you have to ask these questions of how are you going to promote a healthier living if you want a socialized system in the United States? And this will conclude this part of the presentation.
Thank you, Hamza. That these are really interesting things to think about. Like, why is American society, relatively unhealthier? In 2030, it's been predicted that nearly half of Americans are going to be morbidly obese, and have a BMI in the obese range. And it's like we're not doing anything about it. Why is that? Is it because our society benefits from us buying more food? Do we now because we have so much food, it's probably less quality, right? And that might bring up, why is there so much high fructose corn syrup? It's cheaper, right? It helps us mass produce things faster, quicker, makes things more addicting to us. The things that are super dopamine inducing are not always the best things for us. We see that in gambling, for example. Having instant gratification with a $1 snack or $1 menu at McDonald's doesn't necessarily mean it's going to be healthy for your body. So this is a bit of a tangent or a sidebar, but this is my brief plug for lifestyle medicine. That's an area of medicine that is not really focused on in medical education as much, where I believe that the first duty of a physician is to encourage lifestyle modifications. I think that's why we could be part of the change. And if we do promote healthy lifestyles and live it ourselves, by living it ourselves, being role models in the community, this is one way that we can make grassroots level change. All right, now we're going to talk about health insurance, Medicare, Medicaid. I'm sure Obamacare. I've heard that growing up. So just a quick poll, or you just ask yourself. I'm going to ask you rhetorically as well, Hamza. Like, where does your health insurance come from? Does it come from your parents, a spouse, a partner, your school, your marketplace, the VA, or other government coverage?
So for me, I'm currently on my parents' plan.
Yes, I am as well. And actually, about 15 years ago, this was not the case for a large majority of students. They would usually be on the school's health plan. We consider that a lesser quality plan than our parents. It's actually because provisions were increased from, I think, from a younger age, like 18 or something, like a younger age, to now we can stay on our parents' plans until we turn 26. So I know that that is the recommendation, stay on your parents' plan for as long as possible, and then switch to an employer's plan. But of course, you have to be employed to do that. So in 2010, I want to continue that historical discussion. We talked about, the 1800s, 1900s. Now let's talk about 2010. It is 2024 now, but it feels like 2010 is a little bit closer. It was over a decade ago. But basically, during then, the employer subsidized insurance covered approximately 50% of people. There wasn't much of a system beyond that coverage, and there was also like some private non-group insurance that covered about 5% of people, which meant that a large, many Americans went uninsured. There's no system. There was just a private insurance. There was like not as widely used private insurance, I would say. Not all of us, I wouldn't say that a majority of people our age, especially in school, could necessarily afford it. Public insurance didn't exist, and there was no safety net for people who didn't have jobs, as robust, I would say. Medicare, Medicaid did exist, but it was pretty inaccessible, I would say, to people who just didn't have the resources to access them. So there were two types of private insurances, like I said, ESI and then private non-group insurance. Um, Let's go over how ESI works. Basically, employers negotiate prices and benefits with insurance companies. If you worked for an employer with ESI, then you had insurance. So that includes PPOs, HMOs. PPO stands for Preferred Provider Organization. This is actually a screenshot from the USMLE First Aid Step 1 book. So we actually need to know the major medical insurance plans if we're, when you're within the first 2 years of medical school. So good review for me as well. EPO stands for Exclusive Provider Organization. It restricts to limited panel, and it doesn't need a referral, but there are other plans that do need referrals from your primary care provider. And as you can see, it's just there's a lot of I feel there's a lot of nets that are Hamza, you were saying that there's detangled bureaucracy. This is tangled, I would say, because this is so complicated. And I would say a large majority of Americans don't understand most of this till this day. I know that I am asked, when I'm trying to get a waiver from my school, so that I'm not enrolled in the school insurance because I'm on my parents' plan, they ask you to basically put in your insurance information. They ask you, are you EPO, HMO, POA, PPO, or ACO? And I asked them, and they're like, we don't know what this stands for, but it says on your card the acronym. What's very interesting is our insurance cards don't even tell us what the acronyms mean. It just says PPO, HMO, POS. And like we don't, and then the number. It's like we are not educated on this stuff. We have a public education system where we are not educated on our basic tenets of healthcare. And there's a clear gap. And we should ask ourselves, why aren't we as educated about this as we are about, the Civil War or World War II? So, that sort of changes your paradigm and mindset of like, is it something that we are not, it's not public, we can Google it. Of course, we have Google, we have ChatGPT to tell, we have AI, the rise of technology, but we have to actually actively seek this information. And I would say not a majority of Americans, including myself, we don't actively seek this information. All right. So there are advantages to ESI for sure. It increases the risk pool of people, contributing to the insurance. The plans are cheaper and more comprehensive. And yeah, they are more comprehensive for sure. Because the prices are negotiated down. But I am biased, but I will say that there are many more disadvantages because if you lose your employment, you lose your coverage. And small employers or small businesses can't really pay for insurance. It's pretty expensive. So it really de-incentivized small businesses from happening. That kind of plays into monopolies and bigger companies benefiting the most. No mandate stated that employers with insurance must continue to offer it. So at any time, if a company was like, oh, well, we need to decrease insurance or our plans, or just no insurance at all, or just we always, when we're finding jobs, we also want to compare like what are the health insurance benefits that are offered. These are important considerations to make. And this reminds me of one Office episode where actually a lot of when Michael Scott had to, there were budget cuts in the company, and Michael Scott, and this is pre-2010, like I'm saying. So Michael Scott was like, okay, well, we're just gonna have the bare minimum health insurance, which did not cover much, very lackluster, I would say. So, there was no mandate saying that employers couldn't do that. They had the right to do that, as long as they're saying, oh, yeah, we check the box, but is it really comprehensive insurance? It's really up to the company. So I'll talk briefly about Medicare and Medicaid. Now, we should know the difference. How I remember it is Medicare. So Medicare has an A in it. And Medicaid does too, but how I remember is care. You're caring for the elderly. So Medicare is for the elderly. There's also a mnemonic in first aid where the last letter of E is for elderly. And in Medicaid, you're providing aid to people who need it. So for example, low-income people, but another mnemonic is it ends with the letter D. So it's for the disadvantaged people or low-income people. Definitely remember that. Very high yield. So there are 4 parts of Medicare, not Medicaid, Medicare. There's Part A, Part B, Part C, Part D today. Part D, like I told you before, it was introduced in 2006. So there were different parts. Not everyone has all parts. That's important to consider. There are, with Medicare, it insures all individuals who are older than 65. It also covers people with disabilities. It's made up of different parts. They all cover different aspects of healthcare and have different funding sources. So Part A covers inpatient healthcare, which includes the Hospital Insurance Trust Fund. which is sort of from your payroll taxes. Part B is covers outpatient doctor visits, and Part D is a pharmacy plan. Part B and D are actually paid for by the Supplemental Medical Insurance Trust Fund, the SMI fund, where you're enrolled in premiums and the general fund. So it isn't it interesting? It's hard to explain, and it's also hard to understand sometimes. But I'm doing my best. If you have any questions, let me know, or feel free to email us. But yeah, and then Part C is actually private insurance through Medicare. It's like an additional cushion, I would say, if you want to pay a little bit more to have some private insurance. All right. And then, but what Medicare doesn't cover, it doesn't cover it, or it did not cover back then. This is pre-2010 I'm talking about again. So it did not cover it back then. Now it does, but not before. It didn't cover skilled nursing facilities, all preventative care. It didn't cover dental, hearing, vision, all pretty important things. I'm wearing glasses, so I do need that. And then Medicaid is a state-run program that's from the states. It covers low-income individuals and individuals with disabilities. It also now it was also expanded to include low-income pregnant women, children, and elderly. So many students who don't want to opt in for like student health insurance plans, sometimes they opt for Medicaid that once after they turn 26. I know that residency is pretty long, or usually they do offer hospitals do offer health insurance, but this is something even medical students and doctors have to consider. Where is our health insurance going to come in? They say doctors make the worst patients, but we'll see how true that is. But yeah, so Medicaid is funded by both the federal and state governments, but it's like, for example, I'm in Maryland, so Maryland has the Maryland Medicaid programs. Every state is responsible for running their own Medicaid programs. It covers, it's pretty comprehensive relatively because they're state and federally funded, so there are two funding sources. They reimburse, but they reimburse doctors at a lower rate. So in comparison to like other insurance companies. So that's why people would prefer to have like Aetna, United Healthcare, BCBS, Blue Cross Blue Shields over being covered by Medicaid. Now, is there a safety net? Not necessarily, there is a safety net in emergency departments because they cannot decline you care. There's charity hospitals and there's also free clinics, which are all grassroots efforts. And the healthcare system, you'd expect governments to do this. And in fact, Mr. Beast is very popular nowadays. And, he's always saying like, I would expect the government to do these things, all of his philanthropic efforts, but he's the one funding them. So it's sort of like we rely on a lot of philanthropy in this healthcare system through free clinics, emergency departments, and charity hospitals. So yeah, unfortunately, like in 2007, 2008, like I said, pre-2010, there were actually still 45 million Americans uninsured. That is obviously not good. And also the number kept increasing, and then the recession happened, and it just kept increasing. So this was the era pre-2010. Now in 2010, though, Obamacare, or Affordable Care Act, was introduced because the uninsured individuals kept getting charged for more care than they received when they compared to insured individuals. So there was a lot of data that showed that there was a huge need. And so ever since the 1990s, like I said before, there wasn't major health reform or policies or acts enacted until President Obama introduced and signed into law the Affordable Care Act. Now, this is considered a band-aid solution because it was a solution that is already keeps the current system in mind. It was not as polarizing as different political parties sort of make it. It was not the end-all be-all, like the solution to healthcare, and nor was it the worst thing to ever happen in history to the healthcare system, because the data shows that it actually did decrease. You can see this decline and decrease in uninsured individuals versus the people who kept, were stayed being uninsured. So, the thing is that the Affordable Care Act was a band-aid solution, but it did expand coverage. So it actually mandated employers to provide insurance. It mandated individuals to buy insurance as well. But that's no longer true. That they actually repealed that during Trump's administration, where now you don't need to buy insurance now. It's not like you won't be fined if you don't have insurance, and that's up to you now. But back then, from 2010 to 2016, 2017, we had to have health insurance. Now it's no longer a thing, but we are mandated. But now employers are mandated to provide you insurance, so that's not an issue anymore. That office episode, they can't do that anymore. But you do have to have insurance. Now, the quality of insurance remains debated. But that actually led to subsidies for smaller businesses and lower income individuals. So small businesses were also addressed. Like I said, that was an issue because small businesses couldn't afford health insurance. So now small businesses are incentivized and they have they can negotiate lower prices for insurance if they fall under a certain bracket. The Affordable Care Act also, increased increased care in Medicaid. So actually, once it expanded Medicaid funding, actually 36 out of 50 states expanded Medicaid as a result. They made it more comprehensive. I think it started covering dental and vision and hearing. But unfortunately, there were still problems with the Affordable Care Act. There were still premiums in the individual market. The individual markets had few options. And, I'm sure we've all heard of Kaiser, United Healthcare, Aetna, BCBS. So unfortunately, like these individual markets had fewer and fewer options as bigger health insurance companies played a role because everyone wanted to have a job so that they could have health insurance. This increased taxes. But it did make a dent. As a banding solution, like I said, the borough building on top, like it introduced a different set of issues, but it did decrease the number of uninsured individuals. There have been challenges to the ACA since its passage, such as the Trump administration. They wanted to repeal it. That was sort of President Trump's election campaign. He wanted to completely repeal Obamacare. That was a huge conversation because and actually he was a little bit successful. He did repeal some things like I talked about before, the repealing the health insurance mandate. And then also in December 2017, the Congress passed what was called the Tax Cuts and Jobs Act, which eliminated the penalty for that individual mandate. There have been other challenges and court cases kind of exploring the constitutionality of the Affordable Care Act. Like I said, politics and lobbying is very strong in this country. The Trump administration argued at one of these trials called California versus Texas about the ACA mandate. Actually was sort of talking about ACA's protections for people with pre-existing conditions, which included like guaranteeing issue and community rating. Like I said, this is pretty advanced level stuff. As physicians, we do have to have an understanding of health insurance. We are the ones who are going to be explaining it to our future patients. I know that I'm still learning myself. So, like I said, a lot of different court cases have happened, a lot of challenges to the ACA, but it still exists. It has not been repealed. It's still in place. It was still, to recap, it was still a borough of a healthcare system, adding a band-aid on that borough of Ron's house called the borough in Harry Potter. It did expand coverage. It redefined health insurance. It resulted in more individuals getting covered, some improvements in cost control measures as well. But it has been for example, the Republic, since we are a two-party system, it has been like a huge priority, a primary goal of the GOP since its passage to repeal or dismantle it just out of politics. So we'll explore the future of it and some other considerations. But yeah, as I talked about before, it did decline the number of people uninsured. But this is a topic that we'll talk about next week as well on social determinants of health, where unfortunately the uninsured rates for people by race and ethnicity, if you stratify it, are not equal. You can see Asians and white people are the least uninsured versus Hispanics, Asian Islanders, and Pacificers, and Native Americans. They're not as covered or not as robustly covered. So that is something to think about. Why are there differences by race and ethnicity if everyone is an American citizen, or if all these people have jobs, why are we stratifying by race? We'll explore that next week if you're curious. All right, now let's talk about healthcare reform and what we should think about for the future.
So one thing I want to say before we begin this part, it really goes, when you were talking about earlier how complex everything is, it just goes to show that the electorate doesn't know this, like, at all. If we're having trouble understanding, imagine how the electorate feels about this. Um, Sadly, I don't know if there is a push to actually explain how things work to the electorate, and actually that does lead to the next topic now that I think about it. So, going to the next slide or next two slides. Yeah, slogans is something I'm not a fan of. Hashtag Medicare for all. I think we've all heard it. M4A, whatever it is. It's really easy to say these slogans, but you need to decide, how does Medicare for all look like? I don't think that conversation is something that's actually done. So yeah, now you can go to the next slide now. So here are some proposed solutions. I'm not necessarily going to say that either of these solution is the best idea or the worst idea. I'm just saying that these solutions do exist. One solution is going back to a fully privatized system. Now, the system we do have right now is not privatized. Why? Because not only do we have Medicare and Medicaid in the system, but there's also such thing as corporate welfare. These big corporations, whether it's insurance companies or even hospitals, they get subsidies from the government. They get bailed out whenever things are going bad. A fully privatized system, this is something that a lot of libertarians may promote. So Ron Paul, for example, if anybody remembers him, his son, Dr. Rand Paul, is currently in the Senate, though I don't know if he proposes this himself. These people, this ideation say the free market is the best way to help all people. So insurance companies and hospitals, again, they will not be bailed out by the government anymore. Insurance companies and hospitals will be required to compete with one another for lower prices and better quality care. So remember how I mentioned that the English NHS tried to simulate a private system with artificial quotas? Well, these quotas that they're going to face now won't be artificial anymore. So, for example, if a hospital has cheap prices but pretty bad care, maybe some people will go for the cheap prices, but people will probably want to go to a hospital which is a little more expensive but with better care. So that will incentivize this first hospital to either make the care better or they'll have to raise their prices, something like that. And that'll force everybody to compete with one another. And the poor, who usually would be sidelined, they can turn to charity care, which is usually more efficient than governmental social programs. I believe the statistic was that when the government runs certain things, I think 70% of the money goes to just handling the bureaucracy and 30% actually goes to the people it's meant to help. While in charity, it's the other way around, because charity, that money is your money, so you have to be efficient with it. So I think 70% goes to the people it's supposed to help, 30% goes to management. Now, I'm not saying that this is the best solution. Obviously, there's a lot of other questions to ask. How exactly are you going to prevent monopolies from popping up? Obviously, they argue that monopolies would not appear because maybe another company will start up and have even lower prices and all the monopolies have to compete with them. But you have to ask all these questions with this system. And another option that a lot of people say is a single payer system, meaning everybody pays into the system and everybody gets cared for the system. So this would mean the government takes over the healthcare industry entirely, rather than having this weird hybrid system that we have, which I think Manal explained is not working. The Affordable Care Act was just a bandage on this already pretty complicated system, which is having many issues in it. So both of these solutions are pretty radical. Certain services are covered entirely by the government, and private companies may or may not be allowed to exist, depending again on how everything is supposed to work. But when you have these proposed solution, next slide, please. When you have these solutions, you need to ask questions. So first of all, what system are we using? Is our system going to be fully privatized or fully public? If it's a fully private system, will Medicare and Medicaid still be around? Will the government step in during economic downturn? Because that was something that people didn't like. In the 2008 recession, the government came and bailed out a bunch of these big companies, but the average guy who was working his job 9 to 5, struggling, he didn't get any aid from the government. So will the government now, if there's economic downturn, is the government going to help bail out hospitals or insurance companies or not? Will the government make it easier for physicians to get licenses? That's actually something that it's hard to think about, that people don't think about. But if you really think about it, 4 years of undergrad, maybe less depending on how you are, 3 to 4 years of medical school, then 3 to 7 years of residency. you have to be from an American medical school, right? Because international medical graduates have to also enter the system, take these board exams, hope to get residency. I think the government says that only 110,000 residents are taken every year. Is that correct?
Yeah, I would say that there are 40,000 people applying every year. I think that's the most recent statistic from the AAMC, the American Association of
Hmm.
Medical Colleges. But there are still unfilled spots, and there's still a shortage of healthcare providers in this country.
Exactly. So when you have a shortage like this in a country of 300 million people, what do you do now? Obviously, prices are going to go up because there's a higher demand for this care. So will the government make it easier for Americans or people who studied in America to get their licenses? And will the government make it easier for foreign trained physicians to practice? Who knows how many physicians there are in England or France or Spain or Germany or Russia, China, Pakistan, India, whatever these countries are. How many of them have years of experience under their belt? And how many of them just want to live in the US and practice? Many of them can't because they don't want to deal with this whole situation of getting licensing again, going to residency again, all these situations. So will the government make it easier for them? Can charity care be truly trusted to give quality care to the poor? Or will it be just lesser quality care thrown into the poor just so that they're not dying? And what other red tape needs to be cut to lower the prices? All of these questions need to be asked for a fully private system. The thing is that people who actually propose a fully private system do tend to touch on these topics. So that actually takes us to the next slide. Sadly, a lot of people who want a single payer system, which is popular in the US, they don't actually ask these very important questions. So you can say Medicare for all you want on the campaign trail or while you're protesting. But if you don't talk about how it's going to run when you're protesting or on the campaign trail, eventually you're going to have to talk about it when you're sitting down in your seat in Congress or when you're sitting down in your seat in the Oval Office. You have to ask, how much will taxes be hiked on everyone to pay for this? You have to keep in mind that it's not only going to be the rich who are paying for this. The rich already use many loopholes to actually avoid paying taxes. If anybody's going to be paying for this, it's actually going to be the normal person, unless you somehow deal with these loopholes. How will preventative care be promoted to everyone? Right? Because preventative care is something that probably won't be popular in the US. You will have to ban certain foods or restrict certain foods. Will there be programs to encourage exercise? There's just something about American culture. Americans don't like to be told what to do. I don't like to be told what to do, let alone, I can't even blame, other Americans again, say, oh, they're idiots for this. I don't like being told what to do either, right? Are Americans going to like being told, like, okay, you can't eat this anymore. You can't eat that anymore. Every time the government tries to ban certain things, there's always a lot of controversy about it. I mean, just recently, there's still controversy about legalizing marijuana. My state, Jersey, I don't know if we legalized it fully yet or if it's just medically legalized, but there's still a lot of controversy about that. Some people don't want to be told what to do. Some people want it to be completely legal. Same thing when it comes to, say, for example, people who really enjoy McDonald's, right? As much of a burden they'd be on the health system, they don't want to be told that you can't eat this anymore. They like the food. They don't care that it's affecting their health. Their whole mindset is, this is my life. I
My
want to do what I
freedom,
want.
right? I
Yeah,
have the
my
freedom. It's the
freedom. I'm not
culture.
hurting anyone else. I want to eat this, right? So how will you be able to convince the American public that, yeah, now you can't do this anymore? Because that's how a single payer system works. Remember how I mentioned that France, Scotland, even England and Canada, they promote exercise and they ban certain foods. They don't have as much high fructose corn syrup. Even Mexico, actually, they don't. My family, they found soda from Mexico, and we buy it every once in a while. It's more expensive, sadly, so that's why we buy it only once in a while. But it doesn't have high fructose corn syrup in it. And that's just right across the border from a country that's not developed. It's not a developed country, but they have healthier food than us. Why? Because over there, people are willing to accept, like, okay, yeah, I won't take this because it's bad for me. But here, anything the government tells you to do, it's automatically met with suspicion. And there's reason for that. And I'll get into that eventually. But how will the system be structured as well? Is it going to be a federal, like, is the US federal government going to do everything? Is it going to be done by the 50 states? Is each 50 state going to have their own system? Is it going to be done by county maybe? Because different counties can be very different. I just go to school in Pennsylvania. The county, Allegheny County, and Westmoreland County, where I go to school. Allegheny County is where Pittsburgh is. Westmoreland County is where I go to school. Very different. Allegheny County is urban, very urban, because obviously Pittsburgh is there. Pittsburgh dominates that county. Go right over to the east, to Westmoreland County. It's all suburb or completely straight up rural. So is each county also going to decide how they want to run their system?
Exactly.
How
In
do you,
fact, Tennessee, when you're talking about, physicians making it easier for international physicians to come to the US and practice here, Tennessee has actually passed a law that allows international physicians to come without residency because of the healthcare shortage in that state.
no, I hope that goes beyond just Tennessee because,
Yeah.
yeah.
No, I
Um,
mean, science is science, and I think that there is a huge bias, I would say, against international medical graduates, even though the
Definitely.
bodies are the same internationally. But there are reasons why. There's a strong lobbying force of the American Medical Association. Let's think about the Affordable Care Act again. Like, if that was to be repealed, like the many conversations that were happening, not only like 5, 6 years ago and still today, across the country, the New York Times did a study, like about 30 million American people would lose their health insurance if the ACA was repealed completely. There was no substitute proposed, just repeal, repeal, repeal. But what are you going to give instead for these 30 million Americans? That more than doubles the number of people without the health insurance. So on top of that, like if you did repeal the Affordable Care Act, about 1.2 million jobs would also be lost because of the people running that system, not just in healthcare, but across the board. So these are very important considerations to be made. And when talking to our patients about healthcare, about the system, about the lifestyle. And another thing comes up, we are not as educated about international affairs as other countries are about America. We are very focused on local and domestic issues, but we are not as aware about these healthcare systems internationally, which is why I thought it was very important. Even though this is considered an American healthcare discussion, it's important to bring into context other countries in these types of discussions because they often get forgotten or no, we're not because we're America. We are not going to be following, the British. We got, independence from them, right? So it's a matter of like because we have a different culture, like Hamza said, France, England, and Canada all have very different systems. So it's not a question of should we adopt what England is doing? Should we adopt what France is doing? We should try observing what things work for them based on their culture, adjusted for us, because we have a very different culture, from the Red Scare to McCarthyism to America, freedom,
I mean,
eagles, right? That's our
just the
culture.
foundation of the United States is based off skepticism of the rest of the world. I mean,
Exactly.
everything. And the Monroe Doctrine that dominates our foreign policy in Latin America.
Hmm.
The Monroe Doctrine basically says that no other European country is allowed to interfere in Latin America or in the Americas as a whole. That's the US's sphere of influence. That is genuinely a core doctrine that we've had since President James Monroe, I believe. And that was like the fifth president of the US. Um, so you really have to address people when you say, "Oh, look how nice France is," or "Look how nice Germany is." People don't care about France and Germany. They just want to care about like how are you going to make my life better. So you have to
Hmm.
explain that to people, and you have to get on their level. You can't call them idiots because a lot of them aren't idiots. A lot of them genuinely have reasons to be concerned about how the system is going to change their life,
Hmm.
right? And just a final thing I'm going to mention: how are you going to deal with corporate lobbies? Because we mentioned that a lot. We always hinted at it here and there, but corporate lobbies like the insurance lobbies, fast food lobbies, junk food lobbies, these lobbies, they don't want to lose money. They don't want high fructose corn syrup to go away. It makes the food cheap, makes the food addictive. There you go. We sell that to the American people. So you have to deal with all of these factors. You can't just, say whatever. You have to look at everything when you're proposing solutions for the future.
Exactly. When this economy, we're starting to think like, why is America, the top? But you should also think about why is insulin $98 when in Japan it's 14, when in the UK it's $7 for the same insulin. There's no difference in the same insulin medication. It's big pharma. I know that's a term that's thrown around, big pharma. Insurance industries are all aligned. They're massive corporations that are benefiting the most from the middle class of dollar and taxes. All right. Any other closing thoughts, Hamza? That was a pretty strong end.
And no, I think I got all my points across.
Awesome. Yeah, no. All right. Well, thank you very much for tuning in today. Now to access the quiz and to receive certification to this session, you have to go to teleshadowing.com/certification. And next week we'll be talking about social determinants of health. Thank you so much, everyone, for tuning in, and we hope to see you next week. Take care.